Hello, everyone, and welcome to Beyond the Script. I'm sorry I'm running late. I had some emergencies to deal with. I had a patient with congestive heart failure in my office who had some infections. He has a left ventricular assist device, and I had to deal with that, and so time got away from me. So I really apologize for being late, but as they say, the show must go on. I want to talk to you today about congestive heart failure. Congestive heart failure. The term seems more ominous than what it really is in most cases. You think of heart failure, it implies that the heart fails or just goes kaput or stop. But that's not the case. Congestive heart failure, or let me just say heart failure in general. Heart failure is when the heart does not circulate the blood commensurate to the body's needs. And so the thing is that you have a certain situation. Let's say you want to climb some stairs. Then the heart doesn't allow you to climb the stairs effectively. Maybe you get halfway, you get short of breath, you have to stop. That's because you're not circulating the blood adequately. So if the blood is not circulating adequately, blood may back up into the lungs, you get congestion. And so you may have a situation where you get extremely short of breath. Your legs may cramp, so your legs may not function adequately. Other aspects of congestive heart failure consist of when your GI system may not function. People with heart failure have indigestion, so they don't digest their food very well. They don't absorb their medications very well, so their medication may become less effective. So congestive heart failure, or heart failure in general, is when the body does not circulate the blood, the heart does not circulate the blood commensurate to the body's needs. So you're not getting blood and oxygen and nutrients circulating to tissues, to your GI tract, to your brain, to your kidneys, to your liver, to your musculoskeletal system, adequate for those tissue needs. So when that happens, there are two ways it can happen. There's one where the heart is too weak to contract and squeeze the blood out and circulate. There's another situation where the heart, it squeezes normally, seemingly. However, it doesn't relax normally, so it doesn't allow adequate amount of blood and fluid into the system. So So anyway, I'm just having some trouble with my posting here. So anyway, the body doesn't get enough circulation, not because the heart is weak and is not squeezing adequately, but it doesn't relax enough to allow enough volume to go in and therefore enough volume to go out. So we call that a stiff heart or diastolic heart failure. Then systolic heart failure is when the heart, it may allow adequate blood to get in, but it's so weak it doesn't contract adequately. And so therefore it's not squeezing blood out. So I'll give you an example. So let's say you have, let's say a normal circulation is about, 5 liters of blood per minute. And so the heart beats so many times per minute. So let's say a normal amount of blood that goes into the heart is about a liter of blood, or maybe let's say 500 or half a liter, 500 mLs of blood is a normal volume. So if 500 mLs of blood is a normal volume, and the heart normally squeezes out, say 50%. So it squeezes out 250 mLs. So every 4 beats give you a liter. Now, if it's able to squeeze out only 25%, instead of giving you 250 mLs every contraction, it's only giving you 125 mLs every contraction. So it's going to have to contract more rapidly to circulate the blood out on a regular basis. The part of the problem there is that with the congestive heart failure, the heart's going to have to beat faster to circulate the same amount of blood per unit time. So the heart has to work more. And so the more it works, the more it wears itself out. So that's the situation with a weak heart. Let's go back to the same 500 mLs filling in. So because the heart is stiff, it doesn't relax enough to allow the full 500 mLs in. It only relaxes enough to allow 250 mLs in. So instead of 500 mLs of fluid or milliliters of fluid going in, like in the first situation, all 500 goes in, it only squeezes half of it out in a normal situation and only 1/4 of it out in an abnormal situation. That's 125. So with a stiff heart, you only let 250 in instead of 500 in. So in that setting, when only 250 goes in, it only has 250 to work with. Now, let's say it squeezes normally, so it squeezes 50% out. But because it's stiff, only let half the amount in, the 50% that goes out is only 125 mLs. So with a weak heart, it allows the whole 500 mLs in, but it only beats 25%. It only squeezes 125 out. The stiff heart, because it's stiff and it doesn't allow the whole 500 in, it only allows half the amount in. And even though it squeezes more out, the more that it squeezes out is a smaller volume. So that's the situation with diastolic heart failure, systolic heart failure. You have the same amount of circulation, which is decreased from what you'd expect to be 250 per contraction. You only get 125 per contraction. So I hope I'm not losing anybody here. I think I lost a lot of people coming on late, but either way, the show must go on. So what we deal with in cardiology a lot is dealing with patients with a combination of those two. Sometimes it doesn't allow enough in and it doesn't contract enough. And a lot of that deals with the muscle, the heart muscle that's damaged, or the heart muscle tissue, the muscle tissue milieu is abnormal. It could be inflamed, there could be scarring mixed in, there could be dead heart muscle, there could be a variety of things, weak heart muscles, etc. So what we try to do is we try to improve things biochemically and also physiologically. So I'm going to talk about some of those things a little bit. And whenever I talk about our patient with heart failure, we'll talk about our approach in terms of how we improve the heart function as well as the biology or the physiology of the whole overall body. Now, a couple of things I'm going to say about heart failure before I get to today's patient situation. Heart failure in general is such that if the heart is weak and the circulation decreases, the body then reacts in a certain way. So for instance, if the circulation is low, just like I said, 125 mLs per contraction compared to 250, the circulation is cut in half. The kidney measures the circulation. So if the kidney is getting half the amount of circulation and it's seeing half the blood flow, then the kidneys will react by releasing certain hormones. And these hormones are such that they will these hormones are such that they will increase the restriction of blood. They'll also increase retention of fluid and increase the retention of sodium. So what happens is that when the heart starts to fail, the body reacts in such a way that you get increased swelling, you get increased fluid retention, and that's why lots of heart failure patients present with swelling as well as shortness of breath, because they're retaining a lot of extra fluid. So those are the things that we deal with. So the medications we prescribe are things that releases fluid. So maybe heart failure patient gets diuretics. They may get salt-releasing drugs. They get medications that dilate the blood vessels, that allow the flow to the kidneys to improve, allow the flow to other organs to improve, and so on. Hold on one second. I've got somebody at my door. 1 second. Sorry about that. BJ. Go find BJ. Have him open the gate and let those people in. Oh gosh. Zoe. Zoe, go to my truck and open the gate. Okay, first time this has ever happened to me, but as I said, the show must go on, so I apologize. We got 4 people looking. I'm sure you're having a wonderful time. So, as I'm saying, that the heart, when it fails, doesn't circulate adequately. The body compensates in a way to try to improve things, but this compensation improves things for a short period of time. But by retaining more fluid, retaining more sodium, constricting blood vessels, that's a good temporary measure because what the body thinks is that it's in shock. The problem is when this persists over time, restricted blood vessels weakens the heart more. Retention of fluid dilates the heart, and you can dilate the heart and improve its function for a short period of time, but dilating it seriously can make it worse and make you more symptomatic. So anyway, someone's coming in the house, but I think they'll get the message. Go ahead. Yeah. So this is what we deal with. And so much of the treatment for heart failure deals with treating these, what we call compensatory mechanisms that has an adverse effect on the heart. But what I like to talk about is the approach we take. Not only that it can treat these compensatory mechanisms, but it does things with the heart muscle itself to improve the heart muscle function. Now, one last thing I'm going to point out before I get to today's case, and I'm going to kind of wrap it up and give you some more insight. Excuse me. The heart muscle itself, as I said before, is weakened for many reasons. Many times people have multiple heart attacks, which puts scar tissue. It kills heart muscle, so you don't have as much muscle recruitment. The other thing that happens is that scar can form, inflammation. So there's inflammation around the heart muscle gets stiff, the tissue level gets stiff, the heart doesn't relax well, doesn't contract well. So that's a factor in terms of the heart function as well. Now, when you're treating heart failure, typically we treat the hemodynamic factors. However, we have to also do things to improve the heart muscle itself, the muscle function. We do things to decrease inflammation. If we decrease inflammation, the swelling and tissue abnormalities can reverse, and the heart can actually start to function better. So you can get stronger heart function more directly with some biochemical things. So I want to emphasize that 2 aspects of this. There's a biochemical aspect, there's a physiological aspect. Much of what we do in medicine address the physiological aspect, but we don't always address the biochemical aspect as well as you can. So what I want to do is I want to share a slide with you, a few slides that is, and I want to discuss a patient that came to see us a while ago. So this is a patient who flew in from Connecticut. Now, of course, this lecture is being done during the pandemic, and he flew in, of course, during the pandemic, et cetera. He had not been seen by his cardiologist or any physician for about 8 months. He has known heart failure, had type 2 diabetes, hyperlipidemia, was severely short of breath, fatigue, and his ejection fraction, that's the percent blood that the heart pumps out, the example I gave before with the weak heart, his ejection fraction was less than 20%, probably 5 or 10%, so very severe. So in essence, clinical history of heart failure, he had a defibrillator implant. Typically, a patient with congestive heart failure will implant defibrillators to protect them from sudden cardiac arrest. They die of 2 main mechanisms, sudden death, or they also can die of pump failure, in which case the circulation is so low, the organs are perfused poorly, and so on. Now, I'm going to warn y'all, I'm going to have to take a quick break. There's a guy doing some work in the house. I'm going to say something to him, but I'm going to step back. So I've had everything else happen, and except for fire. I hope a fire don't break up, but we're going to get through this presentation. So anyway, so here's the defibrillator. He has type 2 diabetes. Now, diabetes is often a precursor to heart failure. It leads to coronary disease, can also lead to inflammation in the heart muscle, et cetera. He's had a stroke before, has hyperlipidemia, and a strong family history of congestive heart failure. So, and some family members who've had heart transplant. Now, he refused heart transplant himself, and so he wanted to do something natural. That's why he flew down to Houston to see us to go through our program. Now, this gentleman had chest tightness every day. I mean, he would have, at rest. And when we first saw him, he said, look, I would walk a few steps and I get severe chest tightness. Now, he had previous coronary angiograms and was told that he didn't have large coronary artery obstruction that was amenable to bypass or angioplasty or stent. So it was thought to either be due to diffuse disease or some other cause, but he was having chest discomfort, and I'm led to believe that he probably had small vessel disease that just wasn't amenable to bypass. Now, his ejection fraction was less than 20%, as I've said before. So he came here and he saw what we did and came to undergo the nutritional program. Now, here's the situation we were faced with. We saw him for the very first time on a certain day. We had some of his records, but we didn't have any of his blood tests. So I asked him, look, any kidney problems, et cetera. He wasn't aware of any kidney problems. I think his creatinine had been up before in the past, but nothing recent. He was on a high dose of diuretic. He was on a high dose of a heart failure medicine. And here's the medication list here. There were 13 of them. I'll point out the carvedilol was, pretty medium to high dose, but the Entresto, this is a high dose. This is a heart failure medicine. Torsemide, this is a very high dose as a diuretic. He was on a statin drug, he was on insulin and Tradenta. So lots of medicine for diabetes and so on and so forth. So very complex patient, lots of medication, severe heart disease, multi-organ dysfunction. So here we're dealing with, these issues. And so now we have to address, how to deal with his first systolic blood pressure was 96/48, heart rate 78, weight was 230 pounds. So we saw him in the office. We immediately put him on a nutritional detox, raw fruits and vegetables only. We put him on a meal plan from our nutrition center. We decreased the diuretic some. We didn't want to stop it all the way. We didn't know where he was. And we decreased his Entresto some. And when we do the detox, we see them weekly at least. Now, we did a telephone visit about 3 to 4 days after to see what his status was. He was somewhat weak. So we were a little bit, I was concerned because on so many medication, we started the detox itself can be very aggressive. When we saw him the second time, and I'm going to show you these numbers and some graphs later, we had the blood results from the first day we saw him. We saw him about a week later. His creatinine was 5.8. A normal creatinine is about 0.9. So it was more than almost 6-fold normal, which is extremely abnormal. GFR was about 12, 14. At this point, he was at the condition where he really would be a dialysis patient or a kidney transplant patient, at least, in addition to a heart transplant patient. So I was a bit concerned with this, so we immediately stopped the diuretic. Not only did we stop the diuretic, we gave him IV fluids that very day. This was on a Thursday of the week. We gave him IV fluids. He felt terrible coming in, and that second day, his systolic blood pressure, 78 millimeters of mercury. He felt terrible. We gave him IV fluids, gave him 2 liters. He felt much better. We had him go home. He's staying with an Airbnb, went home, and came back the very next day. We see patients very frequent if need be. The next day we saw him, we drew blood that second day we saw him. The next day when we got him back, the creatinine, which was originally 5.8, was 12.4. So that showed me that despite him being on the diuretics and we decreased it, it had gotten worse. So what that told me is that I think this is a matter of dehydration. How much? I don't know. I didn't know what his baseline creatinine was. He thought it was probably less than 2, but he wasn't certain. It was more than 8 months since he had labs drawn, could have been a year. So we're dealing with about a year's worth of absence of data, not knowing his kidney function, et cetera. So at that point, this was a Friday of the week, I admitted him to the hospital. We gave him like another liter or 2 of fluids. He felt better. We admitted him to the hospital. During his hospitalizations, creatinine was around 10, 11, and we hydrated. He must have gotten maybe 10 liters of IV fluid during his hospitalization. During that time, with hospitalization, intravenous fluids, I stopped just about every medication. He was on a detox diet in the hospital. I told him to take his food with him. He had a refrigerator there. He stayed on the raw detox in the hospital. And so we weaned him off just about every medication that he had. So let me show you what we found. So here's the baseline metabolic condition, creatinine 5.08, glucose there, and so on. The GFR is 14. A GFR of 15, below 15 is usually cut off for dialysis. So he was already below that, but I wasn't sure if it was just kidney failure or dehydration. Cholesterol levels, as you see it, he was on a pretty hefty dose of statin, and insulin level, and all of this was high. He had, of course, type 2 diabetes, and he had insulin resistance. Now, look here. We see here that His weight was 230. His weight bounced around. It dropped a lot here. Now, notice we were giving him IV fluids up until, so he came to the office here, and we started IV fluids on around May 25th. His weight still dropped from the 25th to the 26th, but then we started giving more IV fluids. It went up. So from May 29th on, he was giving IV fluids, okay? And we stopped the diuretics. So the weight went back to 229, which is close to baseline IV fluids, but then it started coming back down. Now, so the overall weight loss from here to here was about a 10-pound loss. This is with no diuretics and giving IV fluids to a patient with heart failure, which typically is the opposite. And so the opposite is, and Angela Jones-Henderson said, are we taking new patients? Yes, we are. Let's see, Sammy Jean-Pierre, please, do you have an internship program, some kind of mentoring services? Give us a call. I'm going to put our office number in here, 713-599-1144. Just call and ask to speak to Sierra. She's going to hate me for this, but anyway, I'll say ask for Sierra. But anyway, so his weight went down despite the fact we were giving him IV fluids. And if any of your physicians in the audience, you'll know that giving IV fluids to heart failure patients is something that's a little bit scary to do. We typically diurese them, take fluid off, but we were giving fluid. The reason I did this because I knew he was extremely dry. See, heart failure is not a volume status. Many physicians say, well, how can somebody have heart failure and be dehydrated? No, he was intravascularly volume depleted. So there was less fluid in his blood vessel vascular system because he was over diuresed and the kidneys were just spewing out urine and when he had very little volume. So what we did is that we gave him volume to increase the flow, increase perfusion of the kidneys. And so here's what happened with his kidney function over time. Let me go here. So you see the blood pressure, systolic blood pressure 96, it dropped, it actually picked up, and it kind of stabilized here in the 90s to low 100s when his cardiac function got better. You see the kidney function, diastolic blood pressure normalizing here. Heart rate, 78, it bounced up, came down, but it stabilized, okay, and heart rate in the 80s. We like to have heart rates more in the 70s, maybe even the 60s. For our heart failure patients, we made some adjustments here. Here's the creatinine. We talked about this before. It came at 5.8, which was terrible. It should be way down here. Went up to 12.8, but then as we hydrated him more, it came down. Hydrated him more, and then it got to near normal at 1.8. So here we show, this red line shows GFR. GFR stands for glomerular filtration rate. It's the rate at which the kidneys are perfusing the blood or cleaning the blood. Normal of 15 mLs per minute. Is below that, you go on dialysis. Normal has to be above 60, preferably above 90. So he was way below normal and even below where you need dialysis. So this got worse with the more diuretics. So what happens here with this 5.5 GFR, we stopped the diuretics and we started hydrating. And notice how this got better. GFR got better, stabilized there got better. This is all hydration and medication weaning and detox diet. So I believe the heart might have been getting stronger, but I know definitely what we did was we decreased the diuretics and improve the overall flow just by hydrating the body better. Now, stress test duration, this is important. Now, the different stress test protocols, the Bruce protocol is most aggressive, has the fastest ramp up. The modified Bruce is a little bit slower. So when I show these stress tests, I'm going to show apples to apples. So he went 1 minute on the Bruce protocol the first day he came. After he got hydration and he came out of the hospital, he went almost 4 minutes. So 3 minutes, 42 seconds, 3 minutes. Now that's not super great, but it's 3 times what he did when he came in. Modified Bruce protocol, he did only 4 minutes. Now this is when he first got out of the hospital. As he continued with the detox, he went to 6.5 minutes and over 13 minutes. So he showed some significant improvement in his functional status. He was reporting feeling much better. So we quantify his functional status, which indirectly measures his cardiac function. Heart rate, pre-stress test, which again alludes to resting heart rate, 94, 106 initially. And then this is pre and post. and then it went from 98 to 116 pre and post just out of the hospital. But look here, 80 and 109. So we're able to, and I'm sorry, the green is peak heart rate. So we saw 80 resting heart rate, peak heart rate 130, peak heart rate 109, and 80 here. So we saw a big differential between resting and peak heart rate. That's really what you want to see. You want the resting heart rate low, peak heart rate higher, meaning that you're able to get the heart rate up and so on. So these all show clinical improvement. This is all in a matter of a week and a half to 2 weeks. This is someone who had heart failure for decades. So what we did is hydration, nutritional detox, medication weaning. His performance tripled on the Bruce protocol. Kidney failure essentially went away with hydration. So it really wasn't true kidney failure, but just a lot of dehydration. There's probably a small amount of kidney dysfunction there. And look at this slide. Look at all the medications that we stopped. Okay, all the medication. Now, on the right column here is a beta blocker that's beneficial for heart failure. We put them on vitamin D, coenzyme Q10. Coenzyme Q10 improves mitochondrial function, which indirectly improves cardiac function. Blue-green algae, brain on, which has high micronutrients and minerals. Sea moss, again, high in micronutrients and minerals. He had gout, and instead of giving him an oral medication, we put him on, really wasn't a film patch. This slide's not correct. We put him on a 5% lidocaine cream. He would have it rub it in, and it knocked the gout out. And so he did quite well with that. So this is something to, now he's not quite out of the woods. He had to fly back to Connecticut for family reasons, but he's doing much, much better. We're going to follow him up through telemedicine visit and have him come back down, do some other things. There may be some other medical things he may need. We're not sure if we need to upgrade his defibrillator to a biventricular pacing device, et cetera. All of this is part of an integrative therapeutic approach for this patient with very complex disease. So the point is there's much, much more work to be done. So I, again, sorry for starting late, and I sort of rushed through this. We got, patients at the clinic. And this is the problem you have when you're trying to shuffle information on the airways and manage a busy clinic. But I did want to get this important information out. In summary, here's a very complex patient who has multiple medical problems, came in with lots of medications, and was really at death. So I'm concerned he might have died had he not gotten to us when he did. And so with that situation, we were able to turn things around and help him turn things around very quickly with some very simple things. But the important thing is that you have to look at the physiology, do some of the basic things. More medications is not always the answer. In fact, the answer is more often fewer medications, and more medications, optimal nutrition, hydration, and these things. And so we'll continue to work on this with this patient, and I will keep you posted with him. There's some other patients that we've discussed before, and we'll give you some follow-up. So anyway, again, thanks for joining us, and sorry things got started here with Food RX for Better Health series. And until next time, I'll see you later.